The Art of Tooth Extraction. Picking at Professor Kim's Incorrect Answer Note, Part 1. Hello, I'm Ji-Youn Kim, in charge of this lecture. I am working at the Catholic University of Korea, St. Vincent Hospital in Suwon, South Korea. I am grateful to Professor Park in trusting me with the lecture, and I am very grateful to you who have taken your precious time to listen to my lectures. I think my lecture will be helpful to dentists who have just started clinical practice. Then let's start the lecture. Have you ever had the experience of wanting to raise your hand and help me while extracting a tooth? I have many such experiences, very many. As an oral and maxillofacial surgeon, I still receive many referral papers for difficult tooth extraction cases and unsuccessful cases for extraction. However, I think that each case has its own circumstances. By reviewing cases of failed extractions by other dentists, I hope to help improve your extraction procedures clinically. These are contents of incorrect answer note cases to review together in this lecture. It was divided into before, during, and after extraction. Part 1 lecture will deal with before tooth extraction cases. First of all, before tooth extraction cases. Failure of mandibular IAN block anesthesia and its emergency situations. Hyperventilation syndrome. First case is, it hurts so much I can't breathe. He was an 18-year-old male patient, and he came to our residence because he was uncomfortable with his lower wisdom teeth and wanted to have it extracted. Looking at this x-ray, it doesn't seem that difficult, right? Besides, it's a young patient. So our resident proceeded with local anesthesia first to pick it up. Let's review the medical records for the treatment day. First, IAM block and infiltration anesthesia by the resident. Second, at the first incision, the patient said it was fine. Third, after the flap elevation, the patient said he felt pain. Due to the pain, the surgery was continued, stopped repeatedly until odontectomy was performed. Fourth, the patient continued to complain of pain, lifted his feet, twisted his whole body, hyperventilated, and shivered. Fifth, so the patient was transported to the emergency room. Sixth, the patient vital signs and laboratory examination, including ABGA, showed normal findings in emergency room. However, seventh, so the patient went home without any other emergency treatment. This is post-operative periapical view at that day. This is the remained root. The next day, the patient came to my outpatient clinic. The patient recalled the time of treatment. I felt too much pain. I couldn't stand the sticky saliva going down my throat. At that time, the root was luxated state. I advised the patient to extract the remains because the flap was dirty due to the possibility of infection. After persuading the patient, blood anesthesia was performed. At this time, it was confirmed that the patient's mandibular was positioned posterior-superiorly compared to normal anatomy. After the IAM block, it was confirmed that the sensation of the lower lip became dull. After that, extraction was performed simply. "Oh, I don't feel any pain anymore," the patient said. Can you guess what and why? Maybe at that time the resident was nervous, so she didn't know. However, now that we have regained our calm, we can know. If you look closely at the patient's emergency situation, hyperventilation is the most suspected. Although an ABGA in the emergency room showed restored CO2 partial pressure. What do you think of when you hear the word hyperventilation? Do you remember a woman who can't breathe in the panic situation, then find and blow on paper bag like this picture, like you saw in a movie or drama? Hyperventilation shows symptoms caused by anxiety and fear. It is characterized by deep, rapid breathing. This indicates a drop in the partial pressure of carbon dioxide in the blood. Patients experience numbness around the mouth or fingers, convulsions, and stiffness of the limbs. Initial stage, heart palpitations, upper abdominal tightness, dizziness, nausea, shortness of breath. As the partial pressure of carbon dioxide in the blood drops, facial flushing, respiratory alkalosis, muscle rigidity, and shortness of breath appear. Treatment of hyperventilation is first, rule out other medical emergencies other than hyperventilation. Airway, breathing, circulation, disability, exposure approach. After the dental procedure is stopped, the anxiety factor is removed and the patient is allowed to rest in a raised dental chair in a sitting position. This is important point. In a raised dental chair in a sitting position, not spine position. Encourage the patient to breathe slowly through the mouth. Instruct the patient to slowly exhale and inhale, or breathe again. Encourage the patient to breathe deeply into the belly rather than the chest. It means the diaphragmatic breathing or deep breathing like this picture. Or somewhere in an emergency situation, someone taught me to put the patient as spine position in the dental chair so that the blood goes to the head. Some of you might think so. You're right. However, that's not hyperventilation, but syncope. Syncope is the most common emergency encountered in the dental office, also called vasovagal syncope or simple faint. This picture is a dental serum test from one journal. which is the most frequently encountered medical emergency in the dental office? Is the question. Maybe you could answer the questions. Syncope, right? Characteristic symptoms of syncope include tingling, dizziness, nausea, and turning pale. The cause of syncope is inappropriate cerebral perfusion, causes brief loss of consciousness. Brief is very important point. If it's not a brief loss of consciousness, it's not syncope. If it lasts longer than that, you need call 911 ASAP. It is triggered by pain, stress, changes in position, and hypoxia. The treatment is to lay the patient on their bed or elevate their legs to increase cerebral perfusion. So, do you understand the difference between hyperventilation and syncope? Same cause, like stress or anxiety of dental treatment, but different result and different treatment. Now, troubleshooting of first case. It shouldn't have been painfully treated in the first time. Why did the patient feel pain? It might be because the IAM block was not working properly. Another dentist said that I have a constitution that doesn't work well with anesthesia. Have you heard these stories from some patient? Then why is the IAM block not working? First, a constitution that doesn't work well with anesthesia, individual difference in lidocaine. Maybe it is possible correct answer, I think. However, second, because the needle was not injected in the right place. Maybe it is more possible correct answer. IM block is, I think, it's really difficult. It is a blind technique with an 80 to 85% successful rate. It's too low, you think. Our target is lingular. You could use your left thumb, index fingers, and middle fingers to determine the vertical level of injection point. Injection in the contralateral mandibular premolar, like that, but it rarely succeeds at once. So, when the injection needle is in bony contact, the direction of the needle is changed to backward a little, and it is positioned toward the lingular, parallel to ramus, and then inject, like that. Backward, and change the direction, then inject. Looking at it again, after bony contact is made, like that, the direction of the needle is changed and it is positioned toward the lingular and injected. There are many cases where the IAM block fails while going another direction when moving backward and forward by changing the direction of the needle after bony contact. Are you still failing the IAM block? Then the lingular is more advanced than you think. Inject more upwards, especially if there are no mandibular molars. After bony contact, adjust the angle of the needle differently. Imagine the inside of the mandibular ramus. Adjust the angle of the needle with the mindset of getting as close as possible to the inside of the mandibular branch just above lingular. If you're thinking, oh, it could have gone wrong, it did work right. Don't have false hope. Once again, move the needle insertion part to the posterior and upward and inject. Summary of first case. First, if you think the IAN block did not go well, do not forcefully proceed with the procedure and perform the IAN block once more. A little posterior and upward area than the first insertion point. Second, if hyperventilation occurs due to pain or stress, sit the patient down rather than lying down. Place his or her hands over his or her nose and mouth like cup. Breathe slowly and relax. The second case, failure of history taking a patient with systemic disease, taking antithrombotic drugs. One day, the time around the end of the outpatient treatment appointment, a 64-year-old female patient visited my clinic with swelling on the left side of her face. According to the patient, she had hypertension and type 2 DM. I keep taking aspirin, but I didn't eat today. The left buccal space was swollen. The periapical region of the left maxillary first molar was assumed to be the infection focus. This one. The case was diagnosed as left buccal space cellulitis and abscesses. I told the patient that the bleeding would not stop well. I performed incision and drainage. P-drain was inserted. I prescribed antibiotics and NSAIDs medications. That moment, I feel proud that I had completed today's treatment well. That moment, 30 minutes later, I got a call from ER. Bleeding from the mouth. I performed bleeding control with Hosital and gauze compression. And also 30 minutes later, I got a call from the ear again. Bleeding from the mouth again. After additional anesthesia, P-drain was removed, bleeding focus was checked, blood vessels were ligated with suture, and Hosital was placed and compressed. After struggling to stop bleeding, the patient said, "Did you do well this time?" Oh my, she bleed me. I was so sad. Wait here. How do you control bleeding at extractions? You may hemostasis using pressure with gauze, Hosital, collagen plug, ligation, and so on during surgery. At delayed bleeding after surgery, first of all, while gently washing with saline, excessive blood clots are removed to improve the field of view. If you find a bleeding point, stop the bleeding. Start with accurate pressure to stop bleeding. If pressure hemostasis is not easy due to pain, please perform local anesthesia with a local anesthetic containing a vasoconstrictor. If bleeding does not stop even with pressure, if the bleeding site is the gingiva, please suture or ligation. Electrocauterizing device may be used. If the bleeding site is available, please use collagen plug or Hosital. Hemostasis by suturing a procedure of tooth extraction. Hemostasis by catching the exact bleeding point. It is very important point. So I calmed down and checked patient's medical history again. Is the patient's only medication really aspirin? Through medical record review, she was diagnosed or treated disease as unstable angina and uncontrolled DM. First, unstable angina. She had 3 times PCI. Less intervention was performed before 3 months, very recently. Second, uncontrolled DM. Her HbA1c level is 12.8. It was very high. It was her prescribed drugs. Oh, it's very difficult to dentist. Of these drugs, how many do you know about? I only knew aspirin and diabetes here without looking in the drug handbook. So I looked up the ingredients of the medicine. She prescribed 2 antiplatelet drugs. In addition, she took 3 vasodilators. In this case, the bleeding should not stop. Please think that she was your case. You won't know this cardiovascular situation if she didn't tell you, right? Nowadays, there is diversification of antiplatelet and anticoagulant drugs. This table showed various antiplatelet drugs prescribed to patients in our single medical hospital. If you only knew aspirin, Plavix, Pregail, and warfarin, you shouldn't. In antiplatelet drugs, there are aspirin, Discrin, Plital, Pregail, Clid, Efficient, Brilinta, Amplag, and so on. Did you ever hear NOAC, non-vitamin K oral anticoagulant? If you know only warfarin as an anticoagulant, your knowledge needs to be updated. Up to the 4th generation of NOAC, it has been passed and used by the Ministry of Food and Drug Safety in Korea. In the recently revised guideline, it is recommended first for stroke prevention in patients with atrial fibrillation. There are Pradaxa, Eliquis, Lixiana, Xarelto. These complex antithrombotic drugs, that's a difficult problem, especially to dentists. First, take a detailed medical history. Second, please write an appropriate medical consult to patient physicians. These are the key to solving the problem. So, in 2020, the Korean Association of Oral and Maxillofacial Surgeons has declared dental practice guidelines for patients taking antithrombotic drugs. Professor Jung-Keun Lee wrote about this in detail in the Dental Arirang newspaper. Briefly about this, for managing bleeding risk, standard dental practice guidelines should be followed. Dental procedures are performed only in the morning and only in the week rather than on weekends. Traumatic procedures and local hemostasis return home after conforming hemostasis. The treatment area is limited narrowly and the treatment is divided into several times. Acetaminophen, Tylenol is prescribed for pain relief rather than NSAIDs. Second, management of patients taking warfarin or vitamin K antagonist based on INR level within 24 hours. If the INR level is stable, the INR is always 4 or less. INR level within 72 hours is allowed. INR is under than 4. Maintenance or control of antithrombotic agent administration and dental treatment according to the reply of the medical consult. If INR is more than 4, without dental treatment, refer to an antithrombotic drug prescriber urgently. Patients receiving warfarin after PCI refer to IM or CS because heparin bridging therapy may be needed. Third, management of patients taking antiplatelet agents. Patients administered asterisks for primary prevention purposes. As of 2019, these patients have disappeared, but if there are still such patients, dental treatment after referral to IM, dual or multiple antiplatelet therapy for secondary prevention, dental treatment after referral to IM due to increased bleeding tendency. Patients with complex treatment, since the bleeding tendency is very high, be sure to consult an IM doctors before dental treatment. Fourth, management of patients taking NOACs. Dental procedures with minimal bleeding tendency, dental treatment without stopping antithrombotic drugs. Dental procedures with high bleeding tendency, please dental treatment after referral to IM. In case of taking medicine in the morning and evening, skip the medicine in the morning and receive dental treatment only in the morning of the same day. If taking medicine once a day, dental treatment without stopping taking the medicine. Guidance on taking NOACs after dental treatment. First, rivaroxaban. Patient taking medicine in the morning, take it normally the next morning. Patient taking medicine in the evening, after 4 hours or more of hemostasis confirmation, take the evening medicine on the same day. Apixaban or dabigatran, after confirming hemostasis, take the evening medicine on the same day after more than 4 hours. Fifth, management of patients taking injectable anticoagulants. Referral to a secondary or tertiary hospital is needed. Summary of second case. First, for patients with complex systemic medical history, especially those who are prescribed antithrombotic drugs, put down your confidence and business and listen to patient's systemic medical history one more time slowly. Second, before dental treatment, please send a medical consult to patient IM doctor. Third, remember dental practice guidelines for patients taking antithrombotic drugs. Fourth, in case of an emergency, refer to a secondary tertiary hospital urgently. But there is a more important point. It is important to stop taking antithrombotic drugs, but it is more important to check them again. If the bleeding is stopped the next day after surgery, you must be instructed to take it again. It is always a problem in other surgical parts as well. It can lead to fatal results. Strokes may occur after ophthalmic surgery, and myocardial infarction may occur after orthopedic surgery. Please remember. And third case, failure of history taking of patients with systemic diseases, taking anti-osteoporosis or cancer drugs. The third case is after tooth extraction, pus comes out and the jaw does not open. She is a 65-year-old female patient. She said, 2 months ago, I had my right lower wisdom tooth extracted, maybe this one, at another dental clinic. Since then, the jaw has not opened. Maybe I have TM joint problem. In fact, she couldn't open her jaw. However, she had uncontrolled DM. She had continued to take steroids because her adrenal insufficiency. She was taking an immunosuppressive agent for rheumatoid arthritis. She had dyslipidemia and she was taking bisphosphonate because he had osteoporosis. If so, was the diagnosis ADD without reduction? Closed lock? Really? Absolutely not. Shall we see the X-ray again? Can you see the right mandibular ramus osteolyte change like that? In my case, I can't even open my mouth. My TM joint also hurts. Intraorally, clinically, in right mandibular third molar extraction socket, there was shown a necrotic bony exposure and pus was discharged. There are CT images. You can see the moss-eaten appearance like that, mixed necrotic bone, and discontinuity of the bone. So, she was diagnosed as MRONJ, prescribed antibiotics, and underwent the surgical interventions. What is MRONJ? Oops, it's MRONJ again. It's a hot issue in the dental world these days, right? You are right. It seems to be a hot issue in the dental world where the number of elderly patients is increasing. On this, in 2022, the updated guidelines for medication-related osteonecrosis of the jaw came out. Did you know? This was also well organized and reported by Professor Ji-Youn Kim. Please find and read. MRONJ definition is: first, current or previous treatment with anti-resorptive therapy alone or in combination with immune modulators or anti-angiogenic medications. Second, exposed bone or bone that can be probed through an intraoral or extraoral fistula in the maxillofacial region that has persisted for more than 8 weeks. Third, no history of radiation therapy to the jaws or metastatic disease to the jaws. The next is risk factors. The risk of MRONJ is considerably higher in the malignancy group than in the osteoporosis group. Dental-alveolar operations are the most common identifiable predisposing factors for developing MRONJ. Anatomy factor. Wound is more likely to appear in the mandible than the maxilla or both jaws. Concomitant oral disease. Pre-existing inflammatory dental diseases. In case of sex, higher prevalence of MRONJ in the female. Reflection of the underlying disease for which the agents are being prescribed. For example, osteoporosis or breast cancer. Corticosteroid associated with an increased risk. Anemia associated with an increased risk. Tobacco use is variable reported as a risk factor. There are various bisphosphonate drugs: alendronate, ivandronate, bisedronate, zoledronate, and pamidronate. These days, denosumab is used a lot. Denosumab includes Xdivir, which is used in high concentrations as an anti-cancer treatment, and Prolia, which is used as an osteoporosis treatment. Is there a way to prevent MRONJ as much as possible? No, absolutely no. However, in order to minimize the risk of MRONJ, for aseptic procedure, antimicrobial mouthwash before surgery are performed, and prophylactic systemic antibiotics are prescribed. And also, I personally think this is very important point. A traumatic operation should be performed, and at the same time, adequate securities of inflammatory tissue also is performed. And tooth extraction wounds should be closed appropriately for advanced healing, not primary closure, just appropriate approximation, and it to check the patient periodically. Those that do not heal can be identifiable within a month. The most important thing is the medical concern, prior explanation, and informed consent form. Summary of third case. Please check the patient treatment regimen, duration, and other systemic diseases. Depending on the degree of possibility of MRONJ occurrence, dental treatment is performed properly. Do you take osteoporosis medicine, or do you take it once a week on an empty stomach? Or do you take it on an empty stomach once a month? Or injections every 3 months? Or injections every 6 months? If you don't ask in detail, patients won't tell you first. Please remember. Thank you for your attention. The art of tooth extraction. Picking at Professor Kim's incorrect answer note in the part 1.